Hello, this is Rachel Babin from Oncology News Australia. Welcome to the 30th episode of the Oncology Journal Club podcast. A wonderful milestone, so I'd like to say thank you to you, our listeners, to all of our guests, to everyone who's emailed us feedback and said hi on Twitter, and of course, a big thank you to our hosts, Eva Segaloff, Craig Underhill, and Hans Brennan. This week, we are talking about ctDNA and liquid biopsies. Craig gets us started with a ctDNA for Dummies segment to set the scene and update us on the latest literature. Hans then has two interviews. First, he's speaking with Christian Rolfo, who is the Vice President of the International Society of Liquid Biopsy. And then he chats through the practical uses of this technology with Lizzie Smith, a GI medical oncologist from the UK who you might remember from our ASCO coverage. I hope you enjoy today's entertaining and informative episode. As ever, links to all of the papers discussed today are available in the notes on our website, oncologynews.com.au. Finally, if you'd like to be notified when new podcast episodes are released and receive a free update each week covering all the latest breaking oncology news and a few quirky articles too, then why not sign up to our weekly publication, the Oncology Newsletter? You can get that one for free on oncologynews.com.au. This is Rachel Babin, and this is the Oncology Podcast.
G'day, g'day, g'day. What a treat we have in store today, because we're looking at the topic of ctDNA. It's pretty prescient, it's pretty relevant, it's ubiquitous. ctDNA, it's going to take over the world. But what is ctDNA and how should we use it best? Well, this episode features our wonderful co-host Hans talking to two real experts in the field. And everybody knows what ctDNA is.
Eva, it's Craig.
Hi, Craig.
I don't know anything about liquid biopsies and Hans wants me to review some papers. I'm feeling like a real dummy. Tell me all about it.
Craig, do you know what ctDNA stands for? Okay, Craig, time to do your homework. Look up Wikipedia and ring me back. ... Several days later...
So did Craig already come back to you with the explanation what ctDNA is?
Hans, I can't tell you, only in private. No one would ever have to know, but I don't think he knows what it is. But don't tell anyone, okay? I've sent him away to do his homework and look at it. He's going to ring me back shortly.
I hope he's not going to rap.
Yes, he tends to do that when he doesn't know anything about the topic, doesn't he?
Hey, Eva, it's Craig.
Hey, Craig.
I did my homework, Miss Eva.
Oh.
No, I'm not going to do that again, ever.
No. Tell me, I want to, before you go to Hans, I just want to make sure you know your topic. So I'm going to ask you a few really basic questions. Craig, what is ctDNA? What's a liquid biopsy? Are they the same thing?
No. So the liquid biopsy really describes the process, and ctDNA is a circulating tumour DNA that you can pick up on a liquid biopsy. So liquid biopsy refers to, instead of doing a biopsy of tissue, you can do a blood test to analyse for the presence of tumour cells or tumour DNA. Let me walk you through it, Eva, because I found this nice review paper published this month, actually, in a journal called Cancer Discovery. So it's state of the art, April 2021. It's really a hot topic over the last 10 years. So you can just do a simple blood test. So you can imagine in the tumour environment, the tumour shedding cells, shedding DNA, and the extracellular environment shedding proteins. Extracellular vesicles is one of the proteins that can be detected. And so there's a few steps in the process. Firstly, you need to spin the blood sample to have the cellular layer and the plasma. So in the cellular fraction, you can look for single circulating tumour cells. You can look for clusters of circulating tumour cells, immune cells, endothelial cells, fibroblasts. And in the plasma serum, you can look for various proteins, RNA, circulating tumour DNA, and these extracellular vesicles.
So, Craig, here's your ctDNA quiz that Hans and I prepared. Hans, first question to you.
Yeah, so first question, you say that this DNA is shedded by the tumor, but is it now actively shedded by the tumor, or is it just dead cells that float around and then you pick up the DNA? So is it actively going there or passively? What do you think?
Both.
Oh, a bit of hedging his bets, but it is important, isn't it? Because we do think that it signifies the presence of active tumour, and that's the whole point of picking it up. We'll make a lot of mistakes if we pick up tumour that is dead and use that as a sign that people have got undetected metastatic disease. Is that right, Hans?
That's completely correct, yeah.
So, Craig, go on with your 101.
So I talked about the plasma serum and the cellular fraction, and then there's various processes called enrichment by which you basically discriminate between the tumour cells or the tumour DNA or RNA and the normal cells. So there's various techniques. And so if we use the first, I think, and only technology that's been approved by the FDA to illustrate the kind of field, that's called the cell search technology. So that actually takes an antibody labelled with iron and labels it onto the tumour cells and then uses a magnetic field to separate out the labelled tumour cells. They're enriched and then, detects the presence of them. Sometimes they might use PCR technology to amplify up the DNA or the RNA. And so there's lots and lots of different techniques, but there's only two that are actually registered with the FDA. That's the cell search. And in the field of lung cancer, in the field of EGFR, there's a technique for detecting for EGFR T70M mutation, looking at cell-free DNA. So that's the only two techniques so far approved. And in terms of the clinical utility, there's lots of hope. The main utility is looking to upstage tumours by looking for ctDNA or circulating tumour cells. So looking for basically residual tumour after resection, looking for early relapse, or the emerging field of looking for mutations or resistances developing during treatment. I also found by the same expert, Catherine Alex Pennebier, she actually wrote an editorial in Nature about this field and really urging that we need to move on from exploring new techniques and really doing some randomised clinical trials to prove the clinical utility.
So, Craig, there is another use, and that's for rare tumours where biopsies are very difficult, say cholangiocarcinoma. And if you have one of the classic ctDNA, sometimes we might be able to use that. Did that get a mention?
There's in these reviews, lots of different emerging fields, but again, the point being nothing has yet been proven to be clinical utility.
I just have one remark there, because let's say that you want to do ctDNA for cholangiocarcinoma because you cannot access the tumor. I think it's also important that patients don't receive chemotherapy yet, because I see often in the clinic that sometimes they get chemo and then they want to do a liquid biopsy in between. And of course, you want to have enough DNA in the blood before you take this liquid biopsy. So this is a difference with solid tumors where you just take the tissue biopsy.
But presumably, Hans, if they're resistant progressing, there'll be lots of tumour DNA or circulating tumour cells that you could detect again and then do the test then?
Yeah, that's what you expect. But I think one of the main issues with liquid biopsies is still the methodology. As you correctly mentioned, there are so many methods, so many ways people do it. So there has to be some kind of structural way everybody should do it if you want to compare trials as well.
Fun fact, in September 2020, there was actually 5,700 publications in the realm of ctDNA.
And of course, there are a lot of trials looking at the utility of ctDNA, using it to predict need for adjuvant therapy, need for extra therapy, stopping therapy early, any or all of the above. So, Craig, another for dummies question. Do you always need the tumour DNA so you can compare what you've got in the liquid biopsy, or can you do an unpaired test?
Is it a trick question? I think you can do an unpaired test.
Well, it's a complex question, isn't it, Hans? Do your interviews cover that?
I think this isn't now liquid biopsies.
No, it
for
is.
dummies. This is liquid biopsies for professors.
No, it's not.
No,
It's
a relevant
that's
question.
a fundamental question.
Yes,
it is.
And it comes back to what I already mentioned. It's the techniques they use. So let's say that you want to detect relapse. What you could do is take the tumor, you look which kind of mutations are in there, let's say a RAS mutation, and then when you want to check relapse, you only look in the liquid biopsies for this RAS mutation, this specific one. Or you decide, okay, no, I just want to do a whole bunch of mutations that are common in this tumor type, for example, in colon cancer, and then you just check randomly. Then you don't need the primary tumor. But of course, the more genes you want to detect, want to check, the more costly also the test is. So that's always a matter of deciding, okay, how broad do I want to go? Because you can do whole genome sequencing, but you can also do a selected gene panel, for example. So I think it's a very relevant question.
For pancreas, say you look for RAS mutation because it's 90 to 9%.
P53 is also a good one for a lot of tumors.
P53. Yeah, so that's why it's important, because it's much easier to do an unpaired one than a paired one.
Now you see, Eva, why he was so stressed before the podcast started.
You did a great job.
Fun fact number 2, 557 clinical trials registered on the NCI website for CTCs or ctDNA.
Yep. CTCs went out of fashion because they were never really shown to be very reliable, but they've come back in with some advances in technology. So they will probably turn out to be more useful than shown in the past, I think.
So let's go to the interviews then. So I'm very pleased to have again on the podcast Professor Christine Rolfo, medical oncologist in Baltimore, Maryland, US. And you probably heard him already in the lung, where we also debated about the liquid biopsies in the World Lung Conference. But this time we're here to discuss a bit more about general issues within liquid biopsies when they're used in thoracic oncology. So Christian, welcome again. And maybe a general question. I think for me, the main reason to use liquid biopsies in lung cancer is because biopsies are often difficult to obtain. So is it something that you agree with, that this is the main advantage of using liquid biopsies in lung cancer?
In part, I can agree, but I can disagree as well. So liquid biopsy obviously is a great tool, minimal invasive, that offer the advantage and disadvantage. But in terms of the utility that we have nowadays, not only for patients that we are not able to get biopsies in tissue. So why? Because liquid biopsy is offering an important information and a complete picture about the clonal evolution of the disease, the clonal heterogeneity of the disease that the biopsies in tissues are not offering. So you can have with liquid biopsy, actually, we have robustness enough in liquid biopsy in lung cancer to go for blood first. So I think it's not utopical. We are around the corner for that. It's complementary at this moment of tissue. So in our institution, we are doing tissue and liquid biopsy at the same time because we can catch better information. Obviously, there are some patients still that they are not able to shither. They are not shithers, and you don't have this information, but it's minimal compared with some years ago that the technology was the major limitation.
So it has not fully replaced the tissue biopsy?
I will say that it depends of the case, and we discussed it in the podcast before, the BFAS study, that is a study that is prospective, showing the only source of biomarker profiling the liquid biopsy, and you was able, for example, in the ALK cohort, to have a response rate that are concordant with the tissue. So the activity is similar for drug-able target. So I think we are near to, I will not say replace, but at least having a blood first, if you are able to do it in here in the United States, we have, for example, the liquid biopsy approved for lung cancer and other tumors.
And I think also a major advantage is that you can do it more easily in a serial way, because we are taking blood after taking really biopsies, and blood is a bit more easy, I think. Do you agree with that?
Yeah, obviously that is the monitoring, and you cannot do serial biopsy to the patients. That is clear. So the idea to have a method that is able to give you in real time information, and you can tailor it, the treatment is really fascinating. Actually, yesterday I was seeing a patient that we was tailoring for several times already with different mechanisms of resistance of EGFR. Finally, yesterday, for example, we anticipate with the liquid biopsy to her radiological progression. We detect before that this patient can have and that is fascinating because you can have the opportunity to change the treatment in time before the patient becomes symptomatic. Obviously, departing from a better ECOG or performance status, the patients are able to tolerate better the treatment. And that is really interesting.
And also in terms of resistance, because sometimes you find a major driver. You already mentioned EGFR, but also ROS, ALK, etc. So once you follow these patients with targeted therapy, do you see a lot of acquired mutations that are relevant that you say, okay, now we have to, I think also there are studies with MET amplification acquired. Are there any other targets in lung cancer that are important?
Yeah, obviously. The idea is nowadays we depart from the information from the very beginning. When we identify a target, we are not only interested on the single target, but we are interested in the co-mutations that are companion of this target, because we can have an idea what will happen with this patient in terms of prognosis. Certainly, discovering these alterations, resistant mutations in time is the major goal, no? So we have sometimes drivers and co-drivers that are appearing in a co-mutation in some patients. So clonal evolutions, patients now that they are, for example, in the case of osimertinib, having 797S with or without T17IM. And this is putting in a scenario of reusing TKIs in first generation or not. So the idea that we catch this heterogeneity is fantastic. And I think the patients are able to have a very real benefit with this.
Just to interpret the result of a liquid biopsy, do you look at the percentage of the clone? Is it relevant? Or as soon as you find a target, it's fine? How do you interpret that?
Yeah, the fraction of allelic variant, so we are looking for that, obviously, in general terms. But when you have a drug-able target, if you have a BAF that is very, very low, that doesn't matter, because there are already data published on that, telling there is, regardless of the BAF level, the drivers are trustable. So we can treat the patients and the results are good enough. So that is a common question, because several of the doctors say the percentage of the BAF is very low. I don't believe that this is a target. And I have a big target that is TP53. So I don't believe that this is really a target EGFR. That's not true. So we use the BAF for another concept that is the dynamics right now, to see the clearance of the mutations. There are several studies in EGFR showing that patients after 6 weeks clearance of, for example, after treatment of osimertinib, they have a better prognosis. So we are looking at that. We are also using BAF for immune response in some patients of immunocheckpoint inhibitors, but it's not a consideration that we are doing for target, for distinguish if a target is really a target or not.
And if you then speak about clearance, my first question would be, okay, let's say you have a clearance, you give, let's say, another treatment, and when the target comes back, do you retreat with the same drug? Is it also something that is done in lung oncology? Because that's something we do sometimes in colon cancer, we treat with anti-EGFR. You say, okay, if they have chemo in between, we give back if the RAS mutated clones disappear. Is it the same in lung cancer or not really?
We don't have guidelines for everything, unfortunately. And we don't have clinical trials that are answering all the questions in single patients, unfortunately. But what we can say that, I will put an example. Yesterday, I saw a patient, 3 years, with osimertinib. She was really fantastic time of response. Unfortunately, she progressed. She doesn't want to go for a complete chemotherapy. We discussed with her and we went for a second line, like docetaxel. She was responding fantastically for that. But after a period of time, she progressed. The T17IM that was present before the progression of, at the progression of docetaxel was not anymore present when she progressed, when she had the progression right now. So we can come back to this osimertinib. Yeah, it could be an option for her because she has still a reappearance of the EGFR mutation and there are not other mechanisms of resistance. So the message here is you need to tailor every case. We are discussing the cases in molecular tumor boards. We try to get a real answer for the patients. Obviously, if you have a big portfolio of trials that your patients can enter in the trial is the optimal scenario. But you don't have always trials for everyone because some patients are very heavily pretreated and some patients are not fit enough. And you need to give an answer because the patients are still incapacity to receive a treatment. So liquid biopsy is offering this kind of information that makes still drug-able possibilities for patients.
And I think the lung cancer field is a field which is the most used with liquid biopsies. I think they started first there. So you're quite far there, but what do you think in the future is still needed? From my side, I would think, okay, the cost is still a drawback in a lot of centers to use it routinely or sequential. Or are there some technical issues that you say have to be solved first, or what do you think will happen in the future?
In terms of the first that you say, the liquid biopsy in lung cancer was the first one, yes. And thanks to that, I think lung cancer was opening the door to other indications. And currently we have liquid biopsy approved for prostate cancer, for BRCA in mutations in breast, and we have also the opportunity to use in agnostic tumors to identify mutations or fusions like in TRAC, for example. In terms of limitations, I will say that there are not limitations to make at this moment available in the clinical practice. There is still room for improve, obviously. One of the problems that we have still is the CHIP, the clonal hematopoiesis. In that sense, there are not really a good answer because the companies or the vendors that we have, or in-house even, technologies, they are not able to filter in completely the clonal hematopoiesis. And that was not a problem in some of the tumors because mutations that are typical from clonal hematopoiesis, like JAK2 mutations or TP53, are not really targets. But now when you are facing KRAS, for example, that could be a confounding factor. So I think this could be a minimal limitations. Other limitation is also the patients that are not cheaters, that could happen as well. In my impression is that was happening in a higher number before because the limitation of the techniques, when we was using a technique that was not high sensitive or deeper in the coverage, was easy to lose patients there. For example, if you are using COVAS version 2 for T17IM, you are losing 40% of your patients because the capacity of sensitivity is around 60%. So we need to be aware about these limitations. In terms of room to improve, I think liquid biopsy can also answer in several questions in screening and in cancer interception, for example, that are the new frontiers.
Maybe one final question, because I read somewhere that you're also vice president of the International Society of Liquid Biopsies. I think it's a cool name, of course. So this is your shot to get maybe more members. Can you tell a bit more on the society, what the goal is, what they organize? I know they organize meetings, etc.
Yeah, thank you for the question, because we was creating this society in 2017, far away of the approval that we have this year on liquid biopsy. But the idea was to create awareness and education. So we are trying to get the tools for the clinicians and for patients to understand what liquid biopsy can offer, and to create also a space for the scientific community to meet in, to have brainstormings, and to create projects as well. So we are part of the ILSA, the International Liquid Biopsy Alliance, that is initiative from the NIH. And there are several stakeholders there. The idea is also to create one of these ILSA activities is also the preclinical analytics of liquid biopsy, for example. And there are groups like Blood Pact working on there. So Our society is doing annual meetings and several webinars. Our annual meetings last year was free registration. We have 14,000 participants around the world, and it was a fantastic event with 3 days pre-recorded and opportunity to do also chat questions. We have webinars now. The next webinar is tomorrow in Spain for Spanish language, but we are organizing another one for Asia and United States. So we will have in October our annual congress, and we have an official journal that is Critical Review in Oncology Hematology that is an impact factor of 5.8 that is part of the Elsevier group. So there are several benefits that you have if you became member. It's very cheap, the registration. So we hope that we have a lot of Australians coming there.
Okay, this way you had your free commercial time.
Exactly.
So thank you, Christian. So I hope to speak again in the future, and I would like to thank you for this very super interesting interview. Thanks, Christian.
Thank you very much.
So it's my pleasure to interview Lizzie Smith in this special episode on liquid biopsies. She's a consultant in GI oncology in the Edinburgh Hospital in Cambridge. So Lizzie, we're very pleased to have you here.
Thank you. Thank you for inviting me.
So I will immediately ask my first question. I think you're also fascinated with liquid biopsies and finding ctDNA in the blood, or what's your opinion on this?
Yeah, I think this has been a really useful tool in some cancers, for example, lung cancer, and we've seen good data about the prognostic value of ctDNA and in colon cancer. And my specialty is gastroesophageal cancer, and the work hadn't really been done in large cohorts for resected gastroesophageal cancer. So in the UK, we have a consortium called OCCMS, which has really been dedicated to translational research in resectable esophagogastric cancer. And they collected ctDNA samples on lots of patients. The cohort that we looked at was just 100 patients after surgery. So we just published some research on that in Annals of Oncology, and it was the largest data set that looked at the prognostic value of ctDNA and resected gastric and esophageal cancer so far. So yeah, I'm a fan. So the results were interesting.
So do you think, because you know gastric cancer, still the outcome is not fantastic, so a lot of patients have a relapse, is it really that good in, let's say, if you find ctDNA postoperative that can predict relapse or not?
Well, I think, first of all, it depends. So you're right. About 50% of patients who have perioperative chemotherapy and surgery for gastric or esophageal cancer relapse. And at the moment, we don't really have any means to predict who is going to relapse besides response in the resection specimen and number of lymph nodes positive. And we treat the patients with the same chemotherapy after surgery as we do before surgery. So it will be really useful information to understand who is more likely to relapse. I would say that the tool that you use to detect ctDNA is important. And in the first study that we did, we looked at the ctDNA positivity in patients post-surgery using an off-the-shelf panel, so a 77 gene panel. It wasn't gastric or esophageal cancer specific. And so the sensitivity of that, because it's non-individualized for picking up ctDNA, was modest. So we picked up ctDNA positivity in about 20% of patients. But if we did find those patients to be ctDNA positive, the chance of relapse was much, much higher. So probably about 5 times higher in those patients. Those patients, unfortunately, all did relapse. But that panel is probably not sensitive enough because it's not detecting patient-specific mutations to be used as a tool to detect the minimal residual disease state. But as proof of concept, to show that patients who are ctDNA positive are much more likely to relapse, it was really an excellent piece of research. It was done by one of the PhD students in the lab in Cambridge. Her name is Emma Ocox, so she did a great job.
I think the biggest disadvantage of gastric cancer, and if let's say that you have a colon cancer and you can predict the ones that relapse, what you do is you do more intensive follow-up and you want to find early relapses because you can still cure them. But I think in gastric cancer, even if you find an early metastasis in general, they're not curable. So do you see a value there then?
That's a really provocative question. And so I think there's a number of different ways that you can approach this. So as I said, it's kind of standard treatment for gastric cancer is chemotherapy followed by surgery, followed by more of the same chemotherapy. And if we were to use a patient-specific approach, so bespoke ctDNA panels that, you see various, they've been developed commercially like Signatera in the US. So if we were to use that approach, we could then have we've done some retrospective work and we have a pilot at the moment looking at this prospectively. So if we had a high degree of confidence in the sensitivity and the specificity of the assay, then in fact we could change treatment. I think the first thing that I would like to do is ask the question, can we skip the adjuvant chemotherapy in patients who are negative for ctDNA postoperatively? I think that's quite likely. We'd need to, approach that in a randomized trial. So I think that's our first idea. The second, comment that you made was, well, we're in unfortunately, if a patient has metastatic gastric cancer, it can't be cured by surgery. It's not like colon cancer. But I think that we don't know yet. I mean, that's usually the case in metastatic gastric cancer, which is less commonly oligometastatic. But the state of minimal residual disease is maybe not the same as the state of metastatic disease, where we have these more bulky metastases which are hard to eradicate. So if we've got an MRD positive patient, can it be cured by the same chemotherapy? Could it be cured by a different non-cross resistance chemotherapy? Or what I would really like to see is, can we bring in the treatments that we use in the metastatic setting earlier? Because essentially these patients have de facto stage 4 disease, but it's just a cult. So could we use HER2 targeting therapy? Could we use immunotherapy in patients who are MSI or have a high TMB? And what I would really like to see is a risk-adjusted trial stratified according to molecular profile, bringing in the treatments that are effective in the metastatic setting. So I think that, yes, those patients are less likely to be cured than patients with colon cancer, but at the same time, there are effective treatments in the metastatic setting. And if we use them earlier, before the disease has had a chance to establish itself, it's possibly they could be more effective. So I think that that's what we're going to see over the next couple of years in gastric cancer in terms of trial development.
So we need new adjuvant trials with different arms, let's say, based on the findings, what you have based on the molecular biology of the tumor, etc. So coming back to this HER2 targeted therapy, it's the first and I think one of the best predictive biomarkers in gastric cancer at the moment. But if we speak about liquid biopsies, do you have expertise of finding HER2 amplification in the blood?
That's a great question. So we know if we look for HER2 in the blood, we will identify more patients who are HER2 amplified than we will with biopsy alone. And that's true for many of those biomarkers in gastric cancer. So, for example, EGFR, FGFR, all of those receptor tyrosine kinases that are amplified in chromosomally unstable gastric cancer. So there's been some nice work from Dan Catenacci's group in Chicago, where they've performed biopsies of the primary, biopsies of the metastases, and liquid biopsy. And what we find is, because of that heterogeneity of biomarker expression, is that all of these tools, so biopsy, the primary metastasis, and ctDNA liquid biopsy, will give you extra information. So they're not at the moment. I don't think that liquid biopsy can replace biopsy of the tumor, but they do provide extra information. And, I think it's nice sometimes to watch the evolution of resistance mechanisms, or maybe a fall in the allele fraction of HER2 amplification with effective treatment in terms of monitoring disease activity. But at the moment, I see it as complementary rather than replacing the need for tissue biopsy.
Yeah, I fully agree, because I think HER2 is much more heterogeneous in gastric as we think, because I often do HER2 application. I test within multiple metastases. You have some have it, some have it not. So, and if you detect it in the blood, you never know where it comes from. It's from a bulky disease, from a specific place, etc. So I think it can be indeed complementary, because it seems not to be the main driver there.
Yeah, and I see this as much more important coming through now that we'll have effective second-line HER2 treatments. So we've seen really nice results for trastuzumab deruxtecan, and much more likely to be effective if patients have retained HER2 dependency. So I see a role for liquid biopsies in assessing whether there are any HER2 positive or HER2 amplified metastases in the patient. And I'd like to see it certainly being used as a tool to help more patients find effective treatment.
Okay, with this final remark, I would like to end this interview. It was very interesting. I think a lot of things we can think about, also new study designs and how to go forward with liquid biopsies in GI oncology. Thanks, Lizzie, for this interview.
So all oncologists, surgeons, anyone involved in cancer will be aware now of commercial pressures from ctDNA companies trying to advertise not only to the profession, but in places like America, direct to patients, that there's this test around that can tell them about their cancer and if it's back, etc. So we will face challenges in implementing ctDNA use and CTC use using evidence. So I hope this podcast has been useful, all the way from Craig's Insights for Dummies that was so beautifully outlined, and then our guest interviews. So join us next time on OJC Podcast Special Series, and don't forget our regular episodes. Thank you, Rachel. Thank you very much, Craig.
It's okay, Eva. It was my pleasure to do homework.
And thank you, Hans, for the interviews.
You're welcome. Bye-bye.
Bye for now.
You've been listening to the Oncology Podcast. If you enjoyed today's edition and would like to subscribe, head over to our website, oncologynews.com.au, and sign up to our newsletter. Thanks for listening.